Hello and welcome to The Explainer. In any hospital, there's this invisible shield that stands between a patient and a potentially devastating infection. It's called Aseptic Technique, and it's a super sophisticated, evidence-based approach that is absolutely non-negotiable in modern medicine. So, let's dive in.
To get this right, we're going straight to the source, a really comprehensive academic review on aseptic protocols. This is going to help us understand not just the how, but more importantly, the why behind all the clinical rules that really define wound management today. This isn't just theory. We're talking about the science of keeping patients safe.
So, just think about this question for a second. What is that invisible shield protecting every single patient from infection? It's not just about washing your hands or having sterile tools. It's about a rigorous, disciplined mindset and a set of procedures you just can't skip. That shield, that's aseptic technique.
Okay, here's our game plan. We'll start with why this is so critical, what we're calling the sterile imperative. Then we'll break down the game-changing ANTT paradigm, compare surgical and medical approaches, walk through the four-step aseptic chain, and finally, we'll look at advanced surveillance and what all this means beyond just the patient's bedside.
So our first section, this gets right to the heart of it all. Our skin is our body's main line of defense, so any break in it, whether it's from an accident or a surgery, is basically an open door for pathogens. The entire point of aseptic technique is to combat what we call healthcare-associated infections, or HAIs, and stop a small, local problem from turning into a massive, systemic crisis.
All right, let's move on to the core idea that underpins, well, everything. For a long time, the standard was just this simple idea of clean versus sterile. But modern science demanded something more sophisticated, something standardized. And that's where the aseptic non-touch technique, or ANTT, comes into play.
So, what is ANT, really? At its heart, it's a proactive strategy. Instead of just reacting to possible contamination, ANT is all about identifying the critical sterile stuff before you even start a procedure, and then actively protecting those things the whole time. It's a total mental shift in how we think about sterility.
ANT is really built on two fundamental concepts. First, you've got your key parts. These are the critical bits of your equipment, like the tip of a syringe or the pad of a dressing that will actually touch the wound. Then, second, you have key sites. These are the vulnerable spots on the patient, like the open wound itself. The whole system is designed to keep these two things protected.
Now, what's so cool about this slide is how it brings the whole concept to life. You can see the clinician's gloved hands, the sterile syringe, the dressings, all of those are defined as key parts. And they're being managed so carefully to interact only with the key site, which is the open wound. This is a perfect illustration of that unbroken chain of sterility in action. And this right here, this is the central rule of ANT. Contamination is avoided by ensuring that key parts only ever interact with key sites. It sounds simple, right? But applying that rule with absolute rigor is what prevents infection. It's really the philosophical and practical heart of the entire framework.
Now, it's important to know that aseptic technique isn't a one-size-fits-all kind of deal. Practitioners have to use their clinical judgment to pick the right approach for the right situation. So let's compare the two main types, surgical and medical asepsis. This table breaks it down perfectly. With surgical asepsis, the goal is absolute, 0 microorganisms. That means you need certified sterile gloves and a strictly controlled sterile field. Think operating rooms or really high-risk acute wounds. Medical asepsis, on the other hand, is about reducing the number of pathogens. You can do that with clean, non-sterile gloves in a generally clean area. That's typically used for things like managing chronic wounds. The key is knowing which one to use and when.
Okay, so knowing the theory is one thing, but execution is everything. So now let's see how this theory gets put into practice with a super rigorous procedure, the four-step aseptic chain. It's designed to completely eliminate the risk of cross-contamination. These 4 steps have to be followed in this exact order, every single time. It starts with the environment around you, moves to hand hygiene, then to the specific cleansing technique, and finally to maintaining that sterile field. There are absolutely no shortcuts here.
So step 1 is environmental optimization. Asepsis actually starts before you even touch the patient. By closing doors and windows and limiting who's walking in and out, you minimize air turbulence. And why does that matter? Because it reduces the deposit of bioaerosols, these microscopic airborne particles, from landing on your sterile field.
Step 2. Sequential hand hygiene. This is completely non-negotiable.
It means strictly following internationally recognized standards like the World Health Organization's 5 moments for hand hygiene. You have to do this meticulously before you even think about setting up your sterile field.
Next up, step 3 is isotonic dynamics. This sounds technical, but it really just refers to how you actually clean the wound, and the technique is very precise. You clean from the center of the wound, which is the least contaminated part, outward toward the edges, the most contaminated part. This methodical motion keeps you from dragging bacteria from the skin back into the wound.
And finally, step 4, field maintenance. Once you've set up your sterile field, you have to protect it. This is all about discipline, specifically the 1-inch border rule. See, the outer 1-inch edge of any sterile drape is considered contaminated. Nothing sterile can ever touch this border. It's a simple rule, but it demands constant vigilance.
Aseptic technique doesn't just stop when the dressing is on. The next phase is all about surveillance, using sharp clinical reasoning and new technologies to watch for any signs of trouble.
Modern tech gives us some incredible tools, but they come with their own challenges. Take negative pressure wound therapy. It's super effective, but it requires an even higher level of asepsis, because any breach can turn the whole system into a reservoir for bacteria. At the same time, we've got new biosensors and smart dressings that let us monitor for infections non-invasively, so we can catch problems before they're even visible.
You know, practitioners have to be expert detectives. They're constantly on the lookout for signs of localized problems, the classic signs of infection like redness, heat, and swelling right at the wound site. But they also have to be vigilant for signs that things are getting worse systemically, like a fever or a high white blood cell count, which could mean the infection is escalating to sepsis, and that's a life-threatening emergency.
Okay, in our final section, let's zoom out a bit, because aseptic technique isn't just a clinical task. It has these profound medical, legal, and strategic implications for healthcare pros and the hospitals they work for.
From a legal standpoint, getting this wrong can have really serious consequences. Meticulous documentation proving you followed the right technique is a clinician's legal safeguard. And on the strategic side, hospitals try to reduce risk by using things like prepackaged sterile kits, which just minimize the chance of something getting contaminated during setup.
And this all leads to the ultimate strategic recommendation. The most effective way to make sure aseptic practice happens consistently is to foster a safety culture. This is about creating an environment where doing things the right way is just the norm, where staff feel empowered to speak up if something's not right, and where that gap between knowing what to do and actually doing it is closed for good.
So, the crucial question we're left with is this. In the fight against infection, what really matters more? Is it the flawless technique of one single highly skilled person? Or is it the supportive, safety-obsessed culture of an entire institution? It's a question really worth thinking about as we look to the future of patient safety. Thanks for joining us.